Sending procedure as would be performed as part of a double switch operation. This is a silicone mold model of a 4 years old with ccTGA created from a 3D print. The goal is to reroute and create Y-shaped systemic venous pathway and C-shaped pulmonary venous pathway. As demonstrated with this clay model, in red for pulmonary venous atrium and blue for systemic venous atrium. The C-shaped pulmonary venous pathway will wrap around the superior and inferior limbs of the Y-shape, which then form the cross drainage towards the atrioventricular valve. The sending procedures require very accurate initial incisions to prepare the baffles and then proceeds in 3 layers to create the C-shaped and Y-shaped venous pathway. The venous cannulation has to be at high SVC level above the azygos and low IVC below the eustachian valve. Then the intra-atrial groove has to be developed to help create greater surface area for the baffles. This interatrial groove is the junction between the right atrium and the left atrium. First incision is in the right atrial wall, parallel to the interatrial groove. The incision begins from the level of the base of the right atrial appendage with a gap of 1 diameter of SVC below the SVC origin. And ends above the IVC origin by a distance which is approximately 1 diameter of the IVC. The second incision is now made into the intra-atrial septum to create a rectangular flap from the floor of the fossa ovalis. The incision begins from the medial aspect of the fossa ovalis and then extends superiorly beneath the limbus and inferiorly towards the lateral wall of atrium. Completion of this flap then requires a bow incision through the limbus to reach the lateral wall of atrium beneath the SVC. The atrial wall is thicker here and the incision should almost extend outside of the heart. A right angle instrument can then be passed immediately beneath this incision through the limbus and will emerge exactly through Waterston's groove where the previous dissection has been performed. The third incision now starts from upper end of the SVC from where this opening has just been created and extends inferiorly along the interatrial groove to create a large lateral opening to the pulmonary venous chamber. It is helpful if the surgeon assistant retracts the atrial septal flap medially to enable the surgeon to readily visualize this incision into the left atrium without damaging the atrial flap itself while the incision is extended as inferiorly as possible. The first layer is then created to isolate the pulmonary veins from posterior AV valve by sewing the atrial septal flap into the left atrium. The key landmark here is to start the suture at the midpoint of the base of the left atrial appendage. The suture starts from the roof of left atrial appendage and extends along the ridge between pulmonary veins and appendage. The end of the suture should be dropped deep into the left atrium to create plenty room for the SVC pathway, which will pass above it. Note that the superior component of the suture line is much longer perimeter than the inferior component, so the surgeon should try to use approximately 2/3 of the free edge of the flap to create the superior pathway, and just 1/3 of the inferior component, where the floor of the left atrium can be gathered up with horizontal suture as there is plenty of tissues here. The first layer will leave all pulmonary veins behind the flap while left atrial appendage and tricuspid valve are in front of the flap. The second layer will create the Y-shaped systemic venous pathway by folding the right atrial free wall into the atrium, anchoring it to the interatrial septum. The incision can be extended inferiorly to meet the IVC origin, and the extent will depend on how well developed the eustachian valve is. There is commonly a prominent ridge beneath the SVC created by upper margin of the limbus. If it looks as if it may obstruct SVC pathway, then this can be cut and flattened out by incising vertically and closing with the horizontal sutures. Note that this vertical incision will commonly go outside the roof of the atrium, but as long as the incision is over soon, it will not cause bleeding. If there's a ridge at the remnant of the inferior interatrial septum, then the coronary sinus ostium should be also laid open into floor of the left atrium to maximize the volume of the IVC pathway. In situs solitus and ccTGA, the AV node is usually located anteriorly close to the pulmonary mitral continuity, where it connects to the His bundle, and the AV node is not usually situated in the triangle of Koch. The Y-shaped pathway is created by folding right atrial free wall into the atrium. The suture starts from the mid part of the flap to the remnant of atrial septum immediately deep to the mitral valve annulus and continues superiorly towards the SVC, while avoiding the anterior AV node. Then continue the suture inferiorly towards the IVC. Note how the eustachian valve can be utilized to provide additional tissue for inferior suture line. The suture line can pass close to the apex of the triangle of Koch, as there should be no risk to the AV node in ccTGA. This leaves the coronary sinus flow within the inferior limb of the Y-shaped systemic venous baffle. The third and final layer will now complete the C-shaped pulmonary venous pathway. This is achieved by folding the superior right atrial free wall down to the lateral opening within the interatrial groove in a maneuver like to close the lid of a suitcase. The cutback between the right upper and lower pulmonary veins can be performed to maximize the pathway opening. It is important to leave enough length of upper and lower end of the flap to run around the SVC and IVC limbs so they do not get strangled by the suture line. The length of the flap should be enough to run around external parts of IVC limb. The suture should be done in the adventitia and does not need to be full thickness. The length of flap superiorly should similarly be also enough to run around external part of SVC limb without compressing it. Again, the sutures only need to be to the adventitia. Then suture the rest of the flap to the opening of the intraatrial groove. This layer can be augmented with patch if there is insufficient length. This will result in C-shaped pulmonary venous pathway, which wraps around the Y-shaped systemic venous pathway. The complete model can now be carefully assessed to ensure that both systemic venous pathway are unobstructed and the outer wall can be opened to examine the C-shaped pulmonary venous chamber and ensure that the pathway is widely open.